Welcome to the self-evaluation episode of the ASCO University weekly podcast. My name is Dr. Karen Winkfield, and I am Associate Director for Cancer Health Equity and Director of Hematologic Radiation Oncology at the Comprehensive Cancer Center at Wake Forest Baptist Health in Winston-Salem, North Carolina. Today, we feature a self-evaluation question on the treatment of primary CNS lymphoma, and we begin by reading the question stem. A 45-year-old man presents with headache and blurry vision that has worsened over the last few months. A head CT is done and reveals a 5-centimeter mass that is compressing his right optic nerve. A biopsy is done and is found to have neoplastic B lymphocytes with perivascular cuffing and express CD20, CD19, CD79A, and MUM1. CD3, CD10, and EBV expression are negative. A lumbar puncture is done and sent for flow cytometry, which shows the same expression pattern as above. A CT chest, abdomen, and pelvis is done and shows no other sites of disease. Laboratory results show hemoglobin of 11 grams per deciliter, total leukocyte count of 3, platelet count 210, and lactate dehydrogenase of 312. He is otherwise healthy. What is the most appropriate next step in the management of this patient? Choices: A. High-dose methotrexate regimen. B. Whole brain radiation therapy. C. High-dose chemotherapy followed by autologous stem cell transplant. D. R-CHOP chemotherapy and intrathecal methotrexate. Or E. Codox-M IVAC chemotherapy. The correct answer to this question is A. A high-dose methotrexate regimen. In immunocompetent patients who are young and fit enough to tolerate intensive chemotherapy, the recommendation is to start with a treatment regimen of high-dose methotrexate. Briefly, the other choices presented in this question do not represent the most appropriate therapy for the following reasons. Whole brain radiation is only reserved for elderly and or frail patients who are unable to tolerate chemotherapy. High-dose chemotherapy, followed by autologous stem cell transplant, should only be considered if the patient gets a complete remission to first-line treatment. R-CHOP plus IT methotrexate is not intensive enough for primary CNS lymphoma, as R-CHOP does not have good blood-brain barrier penetration, and IT chemotherapy is not sufficient. While primary CNS lymphoma is a type of diffuse large B-cell lymphoma, R-CHOP plus IT chemotherapy is considered for systemic DLBCL outside the brain that has a high risk of relapse to the CNS. Codox-M IVAC is used for Burkitt lymphoma, but not primary CNS lymphoma. Thank you for listening to this week's episode of the ASCO University weekly podcast. For more information on the treatment of primary CNS lymphoma, visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.